Thank you for joining us in the fourth webinar in our series celebrating 50 years of NIOSH science. The theme of this program is Quantifying and Understanding Impact, NIOSH Epidemiologic and Surveillance Activities. This is our standard disclaimer. Next slide. Before we start, I want to take a minute to remember Dr. Eileen Story, a friend and colleague who worked closely with us in the NIOSH surveillance program. Eileen passed away on September 26th. Eileen was a dedicated physician and public health advocate. She devoted her career to bettering the health and safety of the US workforce, in particular teachers, coal miners, welders, factory workers, and many more. She was one of the many who created the medical specialty of occupational and environmental health. Eileen retired from NIOSH as chief of the surveillance branch in the respiratory health division and professor emerita of medicine at the University of Connecticut Health Center. She will be greatly missed. Today's webinar highlights NIOSH's long and remarkable contributions in the field of occupational health and safety surveillance and epidemiologic research. These presentations illustrate just a small sample of the surveillance and epidemiologic research happening at NIOSH. These scientific efforts are being conducted in most of NIOSH's locations, which are noted by the yellow stars on this map, and by our state and academic partners. Locations of our state surveillance partners are noted by the blue dots. Our guest speakers represent three NIOSH divisions: the Division of Field Studies and Engineering in Cincinnati, Ohio, by Dr. Caitlin Kelly-Reef, the Division of Respiratory Health by Dr. Scott Laney and Jean Cox-Ganser, and the Division of Safety Research by Jeff Funk. Both the Divisions of Respiratory Health and the Division of Safety Research are located in Morgantown, West Virginia. Our two guest speakers, one from California, Dr. Robert Harrison, and one from Texas, Dr. Ketki Patel, represent two of the 22 principal investigators of the states participating in the NIOSH Occupational Health and Safety Program, which we will be talking about later in the program. Our first speaker is Dr. Caitlin Kelly-Reef, an epidemiologist at NIOSH in the Division of Field Studies and Engineering. Dr. Kelly-Reef leads chronic disease studies of workers exposed to ionizing radiation, particularly industrial chemicals. Her mission is to conduct research that informs occupational and environmental standards in the US and globally. She collaborates with several international research consortia and develop large international data sets of radiation-exposed workers. Dr. Kelly-Reef's presentation is NIOSH participation in international pooled mortality studies of chronic disease. Dr. Kelly-Reef.
Thanks, Marie. So today I'll be discussing some of NIOSH's international pooled studies. But before I do that, and in the spirit of today's seminar, I think it's important to give an overview of NIOSH's impactful history of epidemiologic studies of chronic disease in the US. Next slide, please. The overall NIOSH mission is to develop new knowledge in the field of occupational safety and health and to transfer that knowledge into practice. One key component of the NIOSH mission goals is to conduct research with the aim of reducing worker illness. And at NIOSH, this is achieved in our long and successful history of collecting industry records to conduct landmark occupational and epidemiologic cohort studies. Next. NIOSH has established over 70 industrial cohorts of workers exposed to a variety of agents. This slide highlights a few of the NIOSH cohorts that are recent or have provided strong evidence to risk quantification. And landmark occupational studies like these are facility-based industry-wide studies for the most part. This means that NIOSH investigators enumerated large cohorts of workers from rosters based on employment records from facilities. Under the Occupational Safety and Health Act of 1970, NIOSH has the authority to enter workplaces and abstract employee records to conduct health investigations. And this has facilitated the development of many of these landmark cohorts. One of the methodological strengths of these types of record-based studies is that they're very large, they're very well enumerated cohorts, and they have very detailed time-varying exposure information. Next. These types of record-based studies have developed a large body of evidence on chronic disease risks for a variety of occupational agents. The evidence generated by these studies is directly relevant to the development of occupational safety and health science policy, both nationally and internationally. For example, the NIOSH generated research I listed on the previous slide is the foundation of many occupational exposure limits, EPA risk estimates, International for Agency Research on Cancer monographs, national toxicology program evaluations, workers' compensation determinations, and much more. Some key NIOSH studies that exemplify how NIOSH generated research influence workplace protection are benzene, dioxin, and carbon nanotubes, and many more. I only have time to mention some of these briefly, but I think each could really constitute their own talk. So briefly, benzene is an important example of how NIOSH research has influenced not only workplace protection, but also rulemaking itself. The finding of a dose-response association between benzene and leukemia is the basis of the national workplace exposure standards that remain in place today. But the NIOSH study also played an important role in the establishment of modern quantitative risk assessment. And then dioxin risk assessments from NIOSH are of national and international importance and have played a key role in decisions for compensation for veterans. And carbon nanotubes is a more contemporary example of a NIOSH evaluation where an emerging concern was addressed fairly quickly. And we're in the process of developing an industry-wide study on carbon nanotubes based off of a cross-sectional study that was completed a few years ago. NIOSH research has clearly focused on important issues that have led to the prevention of exposure to some occupational carcinogens. And this graph just shows the percent of International Agency for Research on Cancer evaluations that cited for occupationally relevant carcinogens that cited NIOSH work. And you can see that the majority of them have incorporated NIOSH work into their evaluations. And this is just a data-driven example of how NIOSH scientific research strongly influences scientific policy and protection internationally. So now that you've seen a general overview of NIOSH's industry-wide studies, I'll discuss NIOSH's participation in international pooled studies and why they are valuable evidence for occupational safety and health protections. And then I'll also describe some pooled research in progress at NIOSH. So one of the reasons we're involved in more pooling efforts today is because it's an efficient and cost-effective way to conduct research. Establishing and maintaining large occupational cohorts has always been a very time and resource-intensive endeavor. They require the review of workplace records, sometimes for tens or hundreds of thousands of employees. They require good individual level exposure data or the development of a detailed job exposure matrix. And they also require the repeated linkage to disease databases. And so while large records industry-wide records-based industry-wide studies have been instrumental in workplace protections, they're also becoming increasingly challenging to do for a variety of reasons. Finally, the nature of work is changing, and data from individual cohorts isn't always sufficient to address some of the more complex exposures and conditions that workers receive today, or some of the social or organizational factors that impact work and health. The NIOSH industrial cohorts have been and continue to be invaluable in estimating the disease risks from chemical and physical agents, and this is important for risk estimation for both the workplace and the environment. But contemporary workers are different from workers in most of our industrial cohorts. They change jobs more often, they have more precarious employment, less union representation, and are more likely to work in service industry jobs or sedentary jobs. So there's a need for more and different types of data to investigate health issues that afflict these types of contemporary workers. And international pooling could also play a role here as well. And despite these challenges and changes to industry-wide studies, I think there's lots of exciting opportunities in occupational epidemiology, especially at NIOSH right now. These are some of the activities that my colleagues and I are working on to leverage existing data and to address contemporary and future issues in occupational epidemiology. The first is pooling data with other US and international cohorts to improve risk estimates, which I'll discuss in detail later. The second, which is really a variety of activities, is to expand our work in epi methods, policy-based research, and health equity research. And third, as the criteria for the evaluation of chronic diseases evolves to include not just chronic disease endpoints, but also hallmarks of chronic disease measured by biomarkers and other mechanistic evidence, we're looking to establish cohorts that evaluate both biomarkers and disease endpoints. And international pooling can play a role in these types of studies as well. Finally, using new and different types of data to address contemporary and future occupational health issues is another avenue that we're pursuing and could also involve pooling. And these types of opportunities don't necessarily replace the need to continue doing classic industry-wide record studies, but rather are an additional type of evidence for different types of research questions. And today I'll talk a little bit more about how we've used some of our classic industry-wide studies in pooled studies, but I thought it would be important to mention these other directions as well. So participation in international pooled studies is also squarely within the NIOSH mission, which includes enhancing workers' safety and health through global collaborations. And I think that our participation in pooled studies builds some very strong global collaborations because they're direct peer-to-peer collaborations and scientific, science-to-science, scientist collaborations that strengthen the science and decision-making while the research is being done. Engaging in international pooling is certainly not without its own challenges. In fact, it can be fairly difficult, but there's several reasons why it's important and important today. Through pooling, NIOSH researchers and our international collaborators have been able to better answer more complex scientific questions through the pooling of data. For example, there are temporal and environmental modifiers of exposure disease associations that can only be achieved by pooling. International pooling is also essentially the practice of international collaboration. So pooling facilitates knowledge translation and international decision-making. Pooling studies also builds international consensus more quickly since everyone gets to participate in the decision-making of the study as it progresses. And finally, pooling provides more precision and often allows researchers to answer questions that require very high statistical power and to examine risks at a wider range of exposure scenarios. So now I'll discuss two pooled consortia, which I represent at NIOSH, although there are many other active collaborations going on at NIOSH. So NIOSH is a US partner in the Pooled Uranium Miner Analysis, or PUMA. NIOSH contributes data from the landmark Colorado Plateau Uranium Miner cohort, and American Indian workers from those mines are pictured here. PUMA builds on the 1999 Committee on Health Risks of Exposure to Radiation, or BEER-6 study. And to date, BEER-6 has provided the most comprehensive and informative lung cancer risk estimates from radon exposure and is the basis for most radon exposure limits. PUMA is about 3.5 times the size of BEER with 4.3 million person years of follow-up, 20 additional years of mortality information, and 8,000 lung cancer deaths. It also includes 50,000 miners with exposures to radon that were lower than in the BEER-6 study. So new information from PUMA will be able to be used to develop new risk estimates for contemporary and environmental occupational exposure scenarios, potentially at lower levels. And in addition to lung cancer, we're evaluating the joint effect of radon and smoking on lung cancer, cancers other than lung, and other chronic diseases. NIOSH has also been instrumental in the study of workers exposed to ionizing radiation in the US. NIOSH investigators previously published a pooled study of 120,000 workers monitored for ionizing radiation. And this study found an excess relative rate of a variety of cancers, including lymphoma and myeloma. And NIOSH is also a partner in the International Pooled Nuclear Worker Study, or INWORKS, which includes over 300,000 workers from the US, France, and UK. And this study is coordinated by the International Agency for Research on Cancer. And to date, INWORKS provides some of the strongest evidence to strengthen the scientific basis for the protection of adults from low dose and low dose rate exposures to ionizing radiation. And we're currently working on a second update of the INWORKS consortium now. So that's just a quick summary. Next slide, please. I'd just like to thank all of my international collaborators, my collaborators at NIOSH, and everyone who's worked on on chronic disease epidemiology at NIOSH in the past and present. Thank you.
Thank you, Caitlin. Our next presenter is Jeff Funk, who serves as the leader for the Fatality Investigations Team, otherwise known for some people as the FACE program. It's in the Surveillance and Field Investigations branch in the Division of Safety Research. Jeff is an experienced leader and safety and health professional with extensive knowledge of industrial hygiene, occupational safety, regulatory requirements, and consensus standards. Over the past 20 years, he has served in various leadership positions within CDC, NIOSH, and OSHA. Mr. Funk's presentation is NIOSH FACE program, preventing fatalities through the identification of hazards and feasible recommendations to work safety. Jeff?
Thanks, Marie. Gonna present here. So each day on average, a U.S. worker dies every 99 minutes as a result of a work-related traumatic injury on the job. The goal of the FACE program, commonly known as it's the Fatality Assessment, Control, and Evaluation Program, but commonly known as the FACE program, is to prevent occupational fatalities across the nation by identifying and investigating work situations at high risk for injury, and then formulating and disseminating prevention strategies to those that can intervene in the workplace. This is done through a voluntary investigative process that requires cooperation from employers, unions, and workers. Facts and data are gathered from company officials, witnesses, and coworkers. Investigators focus primarily on what is happening just before, at the time of, and right after the fatal injury. The FACE program is a research program, and investigators do not enforce compliance with state or federal occupational safety and health standards, and they do not determine fault or blame. NIOSH publications are developed to highlight these high-risk work situations and provide safety recommendations. These publications are disseminated to priority audiences and are available on the internet through the NIOSH homepage and through a variety of NIOSH publications. The NIOSH FACE program began in 1982. Participating states voluntarily notified OSHA or voluntarily notified NIOSH of traumatic occupational fatalities resulting from targeted causes of death that included traumatic injuries in confined spaces, electrocutions, machine-related incidents, fall from elevation, working youth, and logging. The NIOSH FACE program is active in a wide range of sectors, including general industry, construction, law enforcement, and firefighting. The FACE program has addressed a variety of industry sectors to include agriculture, fishing, construction, and energy production. Since 1989, 15 different states have cooperative agreements with NIOSH. State FACE programs are extramural partners that provide collaborative efforts and expertise to advance the protection of workers and promotes best practices to improve worker safety and health. Currently, 8 state health and labor departments have cooperative agreements and are actively using the FACE model. These states are depicted in green. The yellow and purple states are where investigations have been completed, and the blue states are states in which no FACE investigations have been conducted year to date. In 1998, Congress recognized the need to address the national problem of work-related firefighter deaths, and as a result, funded NIOSH to implement a firefighter safety initiative. The NIOSH Firefighter Fatality Investigation and Prevention Program, commonly known as the Firefighter Program, was created to conduct independent investigations of firefighter line of duty deaths and to recommend ways to prevent deaths and injuries from occurring. Since our program start, we have investigated approximately 40% of all firefighter line of duty deaths. In the 39 years the FACE program has been active, a total of 3,435 reports have been completed. Over the years, FACE investigations have contributed to OSHA's efforts in enforcement, outreach, and rulemaking. FACE investigations have highlighted the workplace dangers encountered by temporary workers, road workers, and powered industrial truck operations. Another effort was a national campaign to prevent falls in construction that was launched in 2012 through the NOR Construction Sector Council with leadership from NIOSH, OSHA, and CPWR, which is also known as the Center for Construction Research and Training. Each year, as part of the campaign, a national stand down is held to focus on fall prevention. NIOSH and state FACE have supported the campaign. Through the years, several state FACE programs, including Kentucky, Massachusetts, Oregon, and Washington, have produced campaign-related videos that highlighted their impactful work. The FACE program has also provided meaningful input to OSHA's rulemaking process through the responses to requests for information, RFIs, and proposed new regulations on topics including communication tower safety and powered industrial truck operations. Examples of publications that use FACE data include NIOSH alerts. NIOSH alerts are designed to present new information about occupational illnesses, injuries, and deaths. Alerts urgently request assistance in preventing, solving, and controlling newly identified occupational hazards. NIOSH has produced various alerts on various topics. A few examples include alerts on skid steer loaders, grain augers, suspension scaffolds, power takeoffs, skylights, excavations, and logging. Workplace solutions are documents that incorporate multiple case studies from FACE investigations and highlight common prevention recommendations. Examples include preventing worker deaths and injuries from contacting overhead power lines with metal ladders, and preventing worker injuries and deaths from backing construction vehicles and equipment at roadway construction sites. Fact sheets present a safety and health message in an easy to understand manner with icons and concise messaging and statistical data. A recent fact sheet focused on preventing construction falls from roofs, ladders, and scaffolds. At the end of my presentation, there's a link to all the FACE publications. NIOSH FACE products are used by employers, workers, and safety professionals to improve worker safety. One example of a FACE product and its impacts include a series of 8 videos that was produced by the American Road and Transportation Builders Association. These videos were based upon NIOSH and state FACE reports that focus on road worker fatalities. These videos focused on lessons learned and were highlighted during the National Work Zone Awareness Week and are currently on the National Work Zone Safety Information Clearinghouse webpage. Monographs are summaries of surveillance data and investigation findings. A total of 4 monographs on topics of worker deaths in confined space, worker deaths by electrocution, falls from elevation, and young workers were produced using NIOSH FACE information. Trade magazines such as Safety Plus Health, a National Safety Council publication, routinely highlight FACE reports. The firefighter program has a long history of justifying the need to improve personal protective equipment and informing the fire service of hazards identified during investigations. One of the first impacts to the fire service was a result of an investigation in which a firefighter suffered a burn over 36% of his body when a flash from an aluminum oxygen regulator released 2 4-foot flames during a routine equipment check. In 1999, NIOSH disseminated a report based on this investigation and partnered with the Food and Drug Administration on a joint public health advisory that was distributed to an additional 29,000 users of oxygen systems. One of the largest positive impacts to the fire service was a National Fire Protection Association, NFPA, 1982 Standard 2007 edition. This NFP standard was revised as a result of information from multiple NIOSH investigations. This revision brought sweeping changes to personal alert safety systems, or PAS, which improved performance of PAS devices by increasing the sound and decibel level and required heat and flame test. Another positive impact, and that's the picture that's on this slide, that's a FACE piece that has been thermally damaged, was a series of heat and flame tests for new self-contained breathing apparatus in the National Fire Protection Association 1981 Standard 2013 edition. These changes affected every SCBA in North America that is certified by NFPA and NIOSH standards, and these new enhanced tests were the direct result of investigations performed by the NIOSH firefighter program and then subsequent interagency cooperation between NIOSH, the NFPA Respiratory Protection Equipment Technical Committee, and the US and international SCBA manufacturers, as well as other regulatory agencies. Various products include alerts and workplace solutions that have been published based upon firefighter investigations. Some of the most impactful workplace solutions include preventing deaths and injuries from firefighters during training exercises and preventing deaths and injuries of firefighters working at basement or other below grade fires. The FACE program continues to evolve over time to meet the needs of our stakeholders and to address the next generation of workers. We are always working to better communicate and disseminate our findings. In an effort to reach a broader audience, the FACE program has implemented the use of visual extensions. Visual extensions are studies that provide a high-level summary of key contributing factors and recommendations that can be used for fire department training. They are designated to be a companion product to the original FACE and firefighter reports. Other products such as infographics rely on visual cues such as icons and graphics to convey an important safety and health message and are intended to be posted in a prominent location within the firehouse. Safety advisories are used by the firefighter program and designed to cover newly emerging hazards and recommendations to ensure the safety of firefighters. Digital stories aim to prevent fatal incidents from reoccurring by telling workers of tragedies and recommendations that can prevent similar incidents from occurring. Digital stories are commonly used as educational triggers and can kick off worker training sessions and facilitate safety and health discussions. Recently, we have focused on firefighter tactics for row houses, and the FACE program envisions enhancements to the format of our reports to reach the next generation of workers. The FACE program looks forward to serving the American workforce by continuing to use the FACE model to identify key contributing factors and recommend feasible control methods that allow the employees to be productive. Special thanks to all those that have contributed to the FACE program over the years. NIOSH staff from the Division of Safety Research, state programs that are currently active, and those that have participated in the past, and the states that have notified us of traumatic injuries. And finally, employers, workers, unions, federal and state OSHA, and industry associations who have supported investigations and have disseminated various NIOSH products. And then lastly, for more information, please visit us online at the Firefighter and FACE main landing page that is listed here. And then also the last link is for publications such as fact sheets, alerts, and other workplace solutions. Thank you for your time today.
Thank you, Jeff. Just a reminder that any questions that you have can be put into the Q&A, which is down at the bottom of your screen. Our next speaker is Dr. Scott Laney. He is a research epidemiologist in the surveillance branch of the Respiratory Health Division. He has completed research studies on topics including coworkers' pneumoconiosis, the transition from film screen radiography to digital radiography and pneumoconiosis classification, and mining populations, including active underground and surface coal miners and studies of former miners. His most recent work includes assisting with CDC's response to COVID-19. Dr. Laney's presentation is Coworkers Health Surveillance Program. Scott?
Thanks, Marie. Today, I'll give a brief background on the Coworkers Health Surveillance Program and present some findings from the program data. Then we'll touch on some studies of respiratory morbidity in coal miners we've conducted using data outside the Coworkers Health Surveillance Program and provide a discussion of some of our current activities and future directions. Worker activism in the 1950s and 60s, including regional and national strikes for improved working conditions and disability benefits, and particularly the Farmington disaster of 1968, where 78 miners died in a catastrophic explosion, led Congress to pass the Coal Mine Health and Safety Act. The act was passed by Congress in 1969 to protect the health and safety of the nation's coal miners, and a couple of key provisions of the act was that it established permissible dust exposure limits and empowered NIOSH to conduct routine health surveillance on active coal miners through the Coal Workers Health Surveillance Program. Operating since 1970, the primary goals of the Coal Workers Health Surveillance Program are the early detection and prevention of coal workers' pneumoconiosis, to study the causes and consequences of respiratory diseases associated with coal mining, to conduct surveillance to monitor ongoing trends and patterns of coal-related respiratory disease, and ultimately to develop improved health and safety standards to protect the nation's coal miners. In broad terms, at about 5-year intervals throughout their working careers, miners are offered chest x-rays at no cost to themselves. In 2016, the program was expanded to include spirometry testing and symptom assessments. Prior to the rulemaking in 2014, the program was limited to actively working underground miners, but in 2014, that was expanded to include surface coal miners as well. Miners can participate during their eligible window at health facilities that NIOSH approves across the country, or by using the NIOSH mobile unit, which travels the country and visits coal mine sites in the communities where miners live and work. The prevalence of coal workers' pneumoconiosis declined sharply following implementation of the Coal Act, which established those dust limits, and this represents all underground actively working miners. By the late 1990s, the prevalence among all tenure groups dropped to below 5%, but sometime around the year 2000, there was a reversal, especially among longer tenured coal miners. And this resurgence has been most markedly observed in Central Appalachia, in the states of Kentucky, Virginia, and West Virginia. This center panel is restricted to miners from Central Appalachia. Currently, the prevalence of CWP in the region we estimate to be over 20% in actively working long tenured miners. We see cases of CWP among working miners in every state where coal is mined, and mostly all of the miners working today who have CWP started working after the 1969 Coal Mine Act. Looking at the trend for the most severe form of coal workers' pneumoconiosis, this is progressive massive fibrosis. The reversal that we've observed is even more apparent. This figure shows coal workers' health surveillance program data from Central Appalachia, where we have the highest prevalence and severity of disease. Prevalence of PMF dropped to nearly undetectable levels in the late 1990s, and in the last 20 years, the prevalence has increased to levels that were higher than they were in the 1970s. This figure shows that nearly 4% of working long tenured coal miners in Appalachia have progressive massive fibrosis. Throughout the history of the program, we've conducted special studies of surface coal miners. As I mentioned, radiographic surveillance is now routinely offered to surface miners as part of the expanded program. And here are recent findings from 6,790 miners we screened between 2014 and 2019. And our primary takeaway here is that pneumoconiosis is occurring in contemporary surface operations, and that it's more common among Appalachian miners and those who perform drilling and blasting operations. And that's a finding that's been consistent over time. Studies of the most severe form of black lung have been a priority for our team, and this has been a particularly concerning issue. Data for our program showed that 1 in 6 coal miners with progressive massive fibrosis in our system progressed from being completely free of lung disease to this end-stage black lung in less than 10 years. So we continue to investigate the cause of accelerated pneumoconiosis and disease progression, particularly post-exposure progression. One of the contributing factors we believe to this increase is increased exposure to respirable crystalline silica. These data are looking at a specific type of lung abnormality on chest x-rays. US miners with R-type opacities are often found to have classic silicotic nodules if lung pathology is performed. And you can see the ongoing increase in this type of lung abnormalities in miners in Central Appalachia, but we aren't really seeing any real change over time with regards to miners with black lung in the rest of the US. So this finding is consistent not only with our overall disease trends, but with some recent exposure assessment studies. In 2016, we began conducting clinic-based investigations, and this involved going to the clinics and validating their medical records and x-rays. And what we did in this case was to review how many cases of PMF, a black lung clinic in Virginia, had seen in a 4-year period. And this is published in the Journal of the American Medical Association, the largest cluster of progressive massive fibrosis ever reported at 416 cases. And our acknowledgement that even for this clinic, it was underestimate based on our restrictive case definition. Moving forward, we continue our focus on underserved communities with our group's latest study describing the prevalence of black lung among Native American coal miners, predominantly in the Western states. We also continue to work to describe disease progression, especially among former miners. And while the pandemic has put our mobile units travel plans on the back burner, we also look forward to travel restrictions being lifted within the next year, so we can continue our outreach to coal mines and mining communities in Central Appalachia. Finally, I just want to reiterate that the work described for you today underscores the importance of surveillance for Black lung and focusing on the health and safety of coal miners. And to offer some perspective and put a face to this disease, NIOSH has produced 2 videos, Faces of Black Lung in 2008 and the follow-up released in early 2020, pictured here, interviewing former coal miners diagnosed with Black lung. Faces of Black Lung 2 features younger miners diagnosed with Black lung, and these are just a handful of the miners affected by the disease. Miners who suffer from this incurable and yet entirely preventable disease. So the NIOSH Coal Workers Health Surveillance Program continues to be an important health program for the nation's miners, and I thank you for your attention.
Thank you very much, Scott. Our next presenter is Dr. Jean Cox-Ganter. She is a senior research epidemiologist and the Associate Director for Science in the Respiratory Health Division. She is author or co-author on over 90 peer-reviewed publications, book chapters, and reports. Her body of scientific work includes research in the many areas of indoor environmental quality, workplace, and associated respiratory health outcomes. She serves as the Associate Director for Science to the Worker Safety and Health Team in the CDC COVID-19 response, and is currently a member of the Advisory Committee on Immunization Practices, otherwise known as ACIP, COVID-19 Vaccines Work Group. Dr. Cox-Ganter's presentation is Indoor Air Quality Investigation. Jean?
Thank you, Marie. As Marie says, today I'm going to be talking a little bit about some of the indoor environmental quality work investigations that we have done over the years. I want to emphasize that poor indoor environmental quality due to dampness and mold in schools, hospitals, offices, retail stores, and other buildings is a common problem in the US and around the world. As an example, indoor environmental quality related health hazard evaluations are a major portion of the total incoming HHEs that NIOSH receives per year. For example, in 2019, 43% of NIOSH health hazard evaluation requests were related to IEQ. And our team in Morgantown started NIOSH-funded research studies on IEQ beginning in 2000. As further background, the Institute of Medicine issued a report in 2004, and the World Health Organization issued guidelines in 2009 based on literature reviews. And 2 of their conclusions were that persistent dampness and microbial growth should be prevented since they may produce adverse health effects, and that if they occur, dampness and mold should be remediated to minimize exposure to microbial agents. The first investigation I want to tell you something about is work we did in an office building from 2001 to 2007. This building, which you see pictured here on the right, had a long history of water damage through the roof, through the balconies, through window flashings, and through unlined brick facade. In fact, the building was built in '85, and water incursions had been reported ever since. The current occupants during the study had moved into the building in the 90s, and then, in fact, were moved out of the building in 2014. But there's approximately 1,300 occupants of this building, and at the time of the health hazard evaluation, the concerns were asthma, hypersensitivity pneumonitis, sarcoidosis, and work-related chest and systemic symptoms. And NIOSH conducted a number of cross-sectional studies on this building over the years. And some of our findings were that occupants were 7.5 times more likely to develop asthma after they started work in the building compared to as adults before they started work in the building. And that we also did some longitudinal modeling of looking at building-related rhinosinusitis symptoms at the start in 2001 and the development of building-related asthma symptoms later on. And we were found that building-related rhinosinusitis symptoms were more likely, occupants with building-related rhinosinusitis symptoms were more likely to develop building-related asthma symptoms, indicating a worsening of the health effects over time for people in the building. We also found that hydrophilic or water-loving fungi in the floor dust were positively associated with post-occupancy diagnosed asthma with an odds ratio of 2.2 for the interquartile range change in exposure. And for us, this indicates that fungal contamination in relation to water incursions and resulting damp indoor conditions is associated with new onset of asthma in the building occupants. In studies in this building on change in health effects related to the remediation, which had continued in the building, some major remediations had been ongoing since 2001 to early 2004, and then more was done in 2006. We did find that new cases of post-occupancy physician-diagnosed asthma and hypersensitivity pneumonitis declined every year since 2001, that employees hired after the major remediation had lower odds of respiratory and non-respiratory symptoms. But we did also find that once building-related symptoms had developed, they did not generally improve in people despite the various remediation activities. I want to change now and talk a little bit about the development of the dampness and mold assessment tool that our Morgantown team did over the years. We had in earlier research in a community college and in a hospital complex found that dampness and mold scores from observational assessments we conducted were positively associated with respiratory health effects. And this gave us impetus to try and develop a standardized approach that building owners and maintenance people could use to conduct observational assessments for dampness and mold. This tool can be used to identify and record areas of dampness and mold throughout the building. It can trigger early repair and remediation to avoid potential health effects and more costly repair and remediation, which occur if building damage is allowed to continue. It creates awareness of potential problem areas in buildings, and it tracks past and present problem areas by repeating the use of this tool. And in the image on the right, you can see this is a sheet. Each area or room in a building that is being assessed will use one of these sheets, and people get the information about the room itself and then fill in information about mold odor, damage or stains in the room, various components of the room, visible mold, and wet or damp. And then these scores can be added up and compared across the building. I'll now talk about an investigation that we did in 50 elementary schools in 2015 and 2016, where we used this dampness and mold assessment tool. We partnered with the school district and the union to conduct a study on dampness and mold in schools and health outcomes in staff. Dampness and mold assessments using the NIOSH assessment tool were done by NIOSH staff, and we did a web-based health questionnaire in which we had almost 66% of teacher participation. We investigated almost 6,500 rooms or areas and found 3/4 of them had water damage and stains, almost 6% wet, damp or wet conditions, 4.3 visible mold, and 3.7% mold odor. Looking at the questionnaire results, we found that 21.6% of teachers reported having asthma ever, 15.5% that the asthma was current, and 9.5% that there was post-higher onset to their asthma. Comparing these values to Pennsylvania adults adjusted for gender, race, smoking, and age, we found almost 30% increase in the risk over the Pennsylvania adults. We also found increased signs of dampness and mold in the schools were associated with wheeze, chest tightness, and attacks of shortness and breath. This was in models adjusted for demographics and mold in the home. So over the years, these are some of the take-home messages that we have developed from our IAQ research. Building-related lung disease exists. Cases are sentinels for co-worker risk. There are consistent associations between health effects and signs of dampness and mold. Building remediation decreases new onset of building-related health effects, but is less effective in resolving established health effects among building occupants. And public health actions should rely on signs of dampness and mold. So these are some resources. Next slide. I have here a link to the NIOSH Indoor Environment Mold page. And there you can find downloadable copies of our NIOSH alert that we published in late 2012, and 2 dampness and mold assessment tools, as you see there pictured, one for schools and one for general buildings. So thank you for your attention. And we would like to acknowledge the many NIOSH staff members and other collaborators who have made very valuable contributions over the years of this work. Thank you.
Thank you, Jean. Really appreciate your contributions there. We're going to turn our attention to the Office of Extramural Programs. So our past speakers were all NIOSH employees, and these two are as well, but they are part of the NIOSH Office of Extramural Programs. Its director, Dr. Alan Robeson, and Captain Linda West, who manages the NIOSH State Occupational Health and Safety Program. This program currently funds cooperative agreements with 22 state jurisdictions that do occupational safety and health surveillance. Alan?
Thank you, Marie. It's a pleasure to be here, and I'm glad to see the great turnout for this webinar. And also, it's a lot of interesting information that I've listened to up until now, and I'm sure the remainders will be interesting as well. So thank you. So this is a little shout out to state surveillance. I'll be very brief. During the prior competition, we started with 21 states and added 5 the following year. Now in FY21, we start out with 22, and we'll see what happens in FY22. We know there's some folks that have sent in applications to recompete their programs, and I think we all hope that we can add a few more. We also added COVID-19 funds thanks to the work of Dr. Margaret Kitt, myself, and Marie Sweeney. We've added COVID-19 funds to various states, one for worker safety and health, and another category for increasing vaccine confidence. So we're glad to do that. It's a lot of extra work to do that on both the part of us and you all as well, but we think that'll pay off. So thank you. And then my last note would be simply to comment on the composition change in the portfolio. We've shifted from 8 fundamental programs to 3, from 11 fundamental plus programs to 6, and from 7 expanded programs to 13. And it's interesting to see the changes in the growth and the work that the state's surveillance programs do and their partnerships and collaborations with NIOSH. Thanks. I'll hand off to Captain Linda West. Thank you.
Hi, everyone. I just wanted to give a couple updates about the state surveillance program. September 14, 2021 was NIOSH's most recent receipt date for the State Occupational Safety and Health Surveillance Program, or funding announcement PAR-20-312. For the applications we received, funding of successful applications will occur by July 1, 2022. We will also have another application receipt date on September 14, 2022. This will be the final receipt date for either revisions, resubmissions, or new applications. The deadline will be 5 p.m. Eastern Time. So I'd recommend that you plan on submitting about 3 weeks in advance, and that will give you time if you have errors to address those errors. In conclusion, our office, the NIOSH Office of Extramural Programs, we're very close to updating our web pages for the state surveillance programs currently funded. And we anticipate that those web pages will be updated within the next 2 weeks. Once updated, you will find a map showing where the programs are located, information about the NIOSH state surveillance program, and program descriptions for the work planned by the currently funded states. The state surveillance program webpage can be located at www.cdc.gov/NIOSH/state-surv.html. Or you can just Google NIOSH OEP state surveillance. That might be easier. If you have questions about any of the information that you've heard today from me, Captain Linda West, feel free to email me at lwest@cdc.gov. Thank you. Back to you, Marie.
Thank you, Alan and Linda. Next slide, please. Our next speaker is Dr. Robert Harrison. Dr. Harrison is a public health medical officer with the California Department of Public Health, Occupational Health Branch, and clinical professor at the University of California, San Francisco, in the Division of Occupational and Environmental Medicine. He established the UCSF Occupational Health Services, where he has diagnosed and treated thousands of work and environmental injuries and illnesses. He designed and implemented numerous medical monitoring programs for workplace exposures, led many work and environmental investigations of disease outbreaks, and consulted widely with many organizations, including federal OSHA and the CDC NIOSH, on the prevention of work-related injuries and illnesses. He has also served as a member of the California Occupational Safety and Health Standards Board. His research interests include the collection and analysis of California and national data on the incidence of work-related injuries and illnesses. Dr. Harrison has authored or co-authored more than 50 peer-reviewed journal articles and more than 40 book chapters, contributed articles, letters to the editor. He is the co-editor of the most recent edition of the textbook Occupational and Environmental Medicine from McGraw-Hill. Dr. Harrison's presentation is State-Based Surveillance, Impact and Opportunities. Dr. Harrison?
Thanks so much, Marie, and my colleagues from NIOSH. I want to thank also all my colleagues at the California Department of Public Health and alumni of our department who are tuning in from around the country in California. I especially want to thank the support from NIOSH, without which the cases that I'm going to show today would not have been possible. We've had a cooperative agreement with NIOSH since 1987 and have collected and analyzed data on workplace injuries and diseases in California and with colleagues from around the country. Next slide. In 1983, the American Journal of Public Health published a paper by David Rutstein, along with fellow colleagues, scientists from the National Institute for Occupational Safety and Health. And he denoted a concept called sentinel events occupational and published a paper on how a list of occupational injuries and diseases that were either implicitly or explicitly occupational could be a warning signal to improve care or prevention, would lead to epidemiologic or industrial hygiene studies, and then would assist the healthcare provider in diagnosis and treatment. So, for example, such diseases would include the most obvious, let's say, mesothelioma, which is explicitly occupational, associated with exposure to asbestos. Chronic beryllium disease with a positive biological marker with a beryllium LPT, explicitly caused by beryllium exposure. Implicit occupational diseases would include examples such as chronic obstructive pulmonary disease, or COPD, which is, of course, associated primarily with tobacco smoking, but is also associated and caused by many different occupational exposures. In 1983, I recall I purchased my first portable laptop computer, which was an Apple Lisa, you'll see on the right-hand side, during the administration of Ronald Reagan. One of my lifetime regrets is that I didn't keep that computer. It's probably extremely valuable at this point, but it was just at the beginning of computer technology. Next slide. This was followed by another paper published by Dr. Ed Baker, Deputy Director of NIOSH at the time, also in the American Journal of Public Health in 1989. And I think Dr. Baker may have been the person that coined the term sensor, Sentinel Event Notification System for Occupational Risk. And he expanded on the concept of the implicit or explicit injuries or diseases caused by work. And he talked about the multi-layered system of public health in the United States at the local, state, and federal level, the concept of the sentinel provider recognizing occupational injury or diseases, reporting it to the state and to the federal surveillance system, and then follow back at the level of the individual worker and work site. And at that time in 1988, you can see that there were 10 states that were operating on the sensor model with conditions that included silicosis, asthma, pesticide poisoning, lead, carpal tunnel, and noise-induced hearing loss. And over the last 30 plus years, multiple conditions have been targeted and placed under surveillance by the state, reported to NIOSH with collaborative studies and multiple publications coming out of this model. Next slide. So I want to talk about 3 examples in California that we've worked on that I think illustrate the importance of this concept, state-based intervention, collaboration, impact, and success in preventing injuries and diseases. The first one is heat-related illness. In 2005, we had several agricultural heat deaths in California. We had a couple of very significant heat waves in the summer of 2005. It led to the passage of the first OSHA emergency regulation for outdoor or exertional heat-related illness among workers. It primarily targeted agricultural workers. California is known as really the fruit and vegetable basket of America. We have several of the largest agricultural counties in the United States that supplies much of the marketplace. And we have millions of both permanent and migratory farm workers in California. Many of these are what I would call vulnerable workers without access to health care, difficult to locate for follow-up, language barriers. And there were several who died of preventable heat stroke in 2005 and then again in 2006. Our heat-related illness standard passed in what I consider to be record time. I think it in total took about 2 years, which for an occupational standard is, lightning speed. And it has 3 essential elements. Has shade, which you can see on the left-hand side, this pop-up tent. Water, illustrated in the middle. You can see that igloo or an equivalent water container. It requires a gallon of water per worker per hour. And then on the right-hand side, it requires employers to provide temporary rest breaks on request by the worker. And this could be up to 5 minutes. And in the original version, it was only once per shift. Now it's anytime the worker requests a break. And then finally, training under our comprehensive injury and illness prevention program. And in the last 10 years, there have been few, if any, confirmed heat-related deaths in outdoor workers in California. This was accompanied by really an unprecedented compliance, OSHA sweeps unannounced, that was joined with wage and hour compliance by our wage and hour division, looking for workers who were not paid their appropriate wages. And I think it's really been, if you look at the data across the country, a very good example of the use of sentinel data, in this case, heat deaths, linked then to an outdoor standard that has prevented heat stroke among workers as the hots get hotter and more frequent because of the impact of climate change. I think this really deserves a lot of attention in other states and on a national level. There is some new regulatory effort by FedOSHA now. And I think the California standard is going to provide an important model. Next slide. The next is diacetyl, also called, as many will remember, popcorn lung originally, because it had been reported a cluster by Dr. Alan Parmet in Missouri that was then reported to the Missouri Department of Public Health and then on to NIOSH, who performed some critical follow-up investigations at popcorn plants in the Midwest. We had 2 sentinel cases in California reported by a pulmonologist that led to an industry-wide study with NIOSH collaboration, and then the passage of the first and only diacetyl standard in the United States in 2010. And since that time, we've had no known, at least to me and my colleagues, additional cases of bronchiolitis obliterans or other diacetyl-associated lung disease. Next slide. And then finally, methylene chloride. We've heard presentation from the NIOSH FACE program. There are several states around the country, including California, that's had a partnership with NIOSH to do fatality investigations. In 2012, Michigan with federal OSHA published a case series of methylene chloride fatality among bathtub refinishers. We've had 3 such cases in California of methylene chloride intoxication, and recently published a very large case series of 80+ cases in the United States that came out in JAMA last year, working with collaborators from other states and NIOSH. This was taken up by a consumer group called Mind the Store, which really focused its effort on the big box stores, led to the removal of methylene chloride from all residential use, and then a ban by the US EPA in 2019. There's still a gap left. Methylene chloride can still be used for commercial purposes, but in the last 5 years, I'm only aware of 1 worker death that occurred in 2020. Unfortunately, that was in a bathtub refinisher. So there's some small gaps, but if you go to the retail stores, you will no longer find methylene chloride. And I think a key spark was the FACE program and the collaboration between NIOSH and multiple states. Next slide. So finally, I see 3 opportunities in the next decade for state-based surveillance. First is the use of electronic health records and data software platforms that can pull electronic diagnoses from medical records. You know, I like to say when I teach healthcare providers, if you see something, say something. If you're aware of a case and you think it's linked to the workplace, it may be the tip of an iceberg, and you should report that case to your state health department, and in turn, they can then trigger an investigation, put out the network alert, find other cases, and connect the dots. Well, I think we probably all know that healthcare providers are extraordinarily busy. Getting them to first take a good occupational history and then report a case might be hit and miss. So I think that the use of electronic health records for what I would call passive surveillance, pulling diagnoses, I think is a really important opportunity. And many of us have been working on this for years. And I really want to thank colleagues at NIOSH for really taking this on and keeping that spark alive to get industry and occupation in electronic health records, and then looking at systems for better reporting. Second is the use of workers' compensation claims that can link workers' compensation claims data with follow-up investigations using employment data to better delineate the denominators and calculate rates. And then finally, the use of employer injury reporting data, which is now required and collected by federal OSHA, and particularly following up on acute hospitalizations that don't necessarily lead to fatalities. I think that could be a a productive use of surveillance data that could really support the ongoing fatality surveillance program in the United States. Next slide. And so finally, on a personal level, I was inspired by a labor leader, Tony Mazzocchi, when I was a medical student, who really talked very much about listening and learning, and then empowering and using our information that we gain from state-based surveillance to work with local community organizations, employer groups, and unions to really understand where we could most effectively apply our scientific knowledge and take that research and implement it into practice. And this is a report you'll see on the left-hand side that I wrote as a medical student about an investigation I did at a chemical factory in New Jersey, where there was an outbreak of hepatitis caused by chlorinated hydrocarbons. Next slide. With that, I'll end and again, thank you and all my colleagues and collaborators.
Thank you, Bob. So our next presenter is Dr. Ketki Patel, and she's from the state of Texas. Dr. Patel is currently the manager for the Environmental Surveillance and Toxicology branch at the Texas Department of State Health Services. And she serves as the principal investigator for the NIOSH-funded Texas state-based Occupational Safety and Health Surveillance Program. She also serves as an environmental and occupational epidemiology subject matter expert in the Texas State Medical Operations Command during and post disasters, and is a faculty member for the DSHS Preventive Medicine Residency Program. I know Ketki was very, very active in the Texas State COVID response. Dr. Patel's presentation is current, emerging, and re-emerging issues in occupational safety and health. Ketki?
Thank you so much, Marie, for the kind introduction. And hello, everybody. Thank you for joining us this afternoon. And it is a great pleasure and honor to share a platform with you, Bob, and several others from colleagues at NIOSH. I also see several others from Texas and other fellow occupational health states as participants. So thank you for joining us. Today, as Marie was mentioning, I'll be covering bits and pieces or highlights of three major topics that we consider as current, emerging, and re-emerging issues in occupational safety and health. And I'll try to go a little faster because I have barely 10 minutes to cover my 24 slides.
Ketki, you have enough time.
Okay, all right. So next slide, please. All right, so the very first topic that we're going to talk about today on current issues in occupational safety and health ties back to one of the initial slides that my colleague, Dr. Harrison, shared in his part of presentation, which was related to sensor pesticides. So what are pesticides? The EPA defines pesticide as any substance or mixture that is intended for preventing, destroying, repelling, or mitigating any pest. It can be used as a plant regulator, defoliant or desiccant, or used as a nitrogen stabilizer. Now, there are several different types or classes of pesticides, and classes are basically given by either the chemical active ingredient that is present in the pesticide or the functionality of that particular product. And currently, there are over 17,000 pesticide products registered and in circulation in the US market. Next slide, please. So what is the continued need for surveillance and prevention for pesticide related exposures, and why particularly for occupational settings? So the first bullet here talks about the global burden of disease study that projected about 44% of farmers are affected by pesticide poisonings each year across different countries, both developing and developed nations. And of most countries globally, there are only a handful of countries that do pesticide surveillance activities, which includes United States, Canada, the United Kingdom, Australia, Finland, and Sweden, which use multiple data systems to keep track of pesticide exposures and illnesses among both working and general populations. In 2019, the US Bureau of Labor Statistics current population survey as many of us know as the CPS, estimated that over 1.1 million workers were employed in farming occupations, which is one of the known occupational groups at risk for pesticide exposures. There are several other occupations and industry groups also that are not known for conventional pesticide exposures use, but as we've seen over the last few years, there has been an increasing use of different cleaning and disinfectant products, which are also considered as pesticides, have been used in different workplace settings, increasing the risk of exposure to different occupation groups, which may include veterinarians, animal handlers, landscapers, maintenance workers, cleaners and janitorial services, etc. Next slide, please. So from a regulatory standpoint or regulatory surveillance standpoint, the US Code of Federal Regulations has one statute, which is under the 40 CFR Part 170 Worker Protection Standard. And this is implemented by the US EPA as part of the FIFRA Act, or the Federal Insecticide, Fungicide, and Rodenticide Act, and provides information and training to workers and employers, as well as healthcare providers on safe use of pesticide products and ensure worker safety and health. Next slide, please. So on this slide, I would ask you all to focus on the chart that you can see on the left, or the map. As you can see, this map is showing data from 2013, focusing on acute work-related pesticide poisoning incidence rate in the US. And as you can see, there are some states that have really dark shaded orange colors or brown colors, showing the high incidence rate of acute work-related pesticide poisonings, and some of which were either data weren't available or the incidence rate was quite low. And the map currently on the slide is generated using the National Poison Data System and can be accessed on the NIOSH website. So as part of different surveillance efforts for pesticide poisoning in our country, we rely on three major systems. One is the National Poison Data System, which is a part of all the poison centers across the country pulling into the data, and then us querying the data through that system. The other one is the US EPA through FIFRA. They keep track of different pesticide-related incidents reported to their system. And then last but not the least is the sensor program that Dr. Harrison mentioned in his slide. And sensor stands for Sentinel Event Notification System for Occupational Risk. And currently the sensor program has one of the priority conditions that we focus on is pesticide poisoning. And currently we have 13 states that participate in the NIOSH sensor pesticide programs and provide data on acute pesticide-related illnesses and injuries. Next slide, please. So the NIOSH sensor pesticide model is quite unique. And why is it unique? It's unique because it provides the state level capacity building guidance from the federal level. It also allows the states to focus on their priority populations rather than one size fits all approach. It also allows data gathering from local and state level up to the federal level. So as states participating in the NIOSH sensor pesticides program, these participating states provide data to NIOSH, which is being further shared with EPA and other stakeholders and researchers for timely interventions. And this also fosters local, state, and federal partnerships. Next slide, please. In most states, as we know, pesticide exposures and related injury or illness is not a reportable condition. And not all pesticide exposures result in adverse health effects where a worker or an individual may seek medical care or call the poison center for further assistance. And therefore, that adds to the challenges in surveillance, such as underreporting. Another issue is additional challenges of surveillance involving vulnerable worker populations, such as farm workers, migrant and seasonal workers, workers for whom English is not their first language. And that adds to additional barriers, including communication barriers or education and outreach barriers on how to creatively and effectively communicate the public health messaging to reduce the exposures in these working populations. And last but not the least, we don't have all the resources at disposal. So we always have challenges in terms of how much funding we have, or how much manpower we have, or how much skill set we have available to continue the surveillance and outreach activities at a state level. Next slide, please. So with that, we're going to switch gears to one of the hot topic worldwide over the last 2 years, which is the coronavirus disease 2019 or COVID-19 pandemic. Next slide, please. Let's take a look at the timeline of COVID-19 pandemic. And by no means this is a comprehensive timeline. The reason that we're focusing only on few key highlights is so that we guide the next few slides of our discussion during this talk. So as you can see on this timeline, in 2020, the first case of COVID-19 was detected in Wuhan, China. And then later on, when we fast forward, we also see that COVID-19 was declared as a national emergency in the US in the month of March. And right after that, on March 15th, the territory of Puerto Rico was the first one to announce a stay-at-home order, followed by which the first state to order a stay-at-home order was the state of California on March 19th, and other states followed. However, most of the states began rescinding or lifting these stay-at-home orders by the end of May or early June 2020. And this is a critical piece of information in aspects of the timeline, because this is when we also saw a lot of widespread community transmission and also a lot of work-related workplace outbreaks of COVID-19. Next slide, please. Over the last 2 years, several of us were introduced to a lot of different concepts, terminologies, and new information. One of which for most of us at the state level was the instructions or guidances coming out that aligned, especially for essential workers or critical infrastructure workforces. So CISA, which is the Cybersecurity and Infrastructure Security Agency of the US, identifies 16 industrial infrastructure sectors whose assets, systems, networks are considered to be absolute paramount and vital to the United States, that their incapacitation or destruction would have a debilitating effect on the security, national economic security, and public health and safety. So why does it matter? Next slide, please. When it comes to state-based occupational safety and health, as I'm sure several of the participants from different states make echo and be able to relate to this, that all of us got pulled into some or the other level of COVID-19 efforts, whether it was assisting in case investigations or contact tracing or just providing some data expertise and so forth. So when we recollect the timeline slide that we saw that March through July 2020, several of the states began observing widespread community transmission of COVID-19. And also not everybody could stay at home and telework. As we saw, some of those critical infrastructure workers identified across those 16 industries or 16 industry sectors had to go into work. And some of those might include, healthcare facilities, long-term care facilities, prisons and correctional facilities, manufacturing sector, etc. And so we began starting to observe outbreaks in these settings. And states have had a varying degree of response and efforts involving occupational safety and health in relation to the COVID-19 pandemic, which may have involved also going into these facilities to do facility assessments, epidemiologic investigations, building the local and state capacity for collecting information on work, industry, and occupation. Also, how to best reach out to hard-to-reach worker populations and communicate public health messages for preventing COVID-19 exposures. And also providing additional technical assistance and consultations to employers and businesses. Next slide, please. Further moving on, when we saw in that timeline, I know we didn't go into the details, but when we fast forward in that timeline to December 2020, we had our first vaccine that was under emergency use authorization by FDA, which was the Pfizer vaccine, and followed by which was Moderna, and a couple months later was the Johnson & Johnson. So US has 3 vaccines that are currently being administered to populations. And so as part of those vaccination efforts, obviously the state-based occupational health programs were involved not just in the epidemiology aspect of data collection and contact tracing, but also providing additional assistance in terms of manipulating workforce data sets and identifying high-risk industry and occupation groups that were at high risk for severe illness. and communicating that information to the vaccine administration teams and in their respective states. States were also instrumental in helping reach out to these vulnerable worker populations and building vaccine confidence, as some of you also heard in the previous presentations about how NIOSH has provided resources, tools, and additional support to states so that way they can use those funding to conduct education and outreach activities for building vaccine confidence among people. In addition to some of those epi and vaccine related, there were other logistic support that also several state occupational health programs provided, which may include answering questions or assisting with the purchase of personal protective equipment. Or people were rampantly using disinfectant and cleaning products, and that resulted in a lot of different kinds of chemical exposures, which also needed additional surveillance as well as education and outreach to prevent these exposures. And so that kind of also went hand in hand in addition to other COVID-19 response activities. Next slide, please. Alongside NIOSH, as well as all the other states, the Council of State and Territorial Epidemiologists comprised a work group for COVID-19 outbreaks. And the work group consisted of members representing state health departments, CSTE members, as well as NIOSH representatives who tirelessly worked from May through July 2020 to publish 3 unique outbreak definitions and interim guidance so that way states and local health departments have some form of a pathway on how to prioritize and how to proceed with different kind of outbreak investigations. For example, where do we stop? Whether do we go into every facility to check whether all the measures for COVID-19 prevention are in place or not? Or do we collect information about all the people who are exposed, or what is the extent of education and outreach required? How long should we follow up for a particular outbreak? All of those were combined and put into these 3 different setting specific outbreak definitions and guidance, which you can access through these links on the slide. Additionally, the CSTE Occupational Health Subcommittee also convened 2 work groups that focused on producing evidence-based guidance and tools, further detailing how to determine and classify work-relatedness for cases of COVID-19 and close contacts, as well as occupational exposure risk based on a person's occupation or job task. Next slide, please. As with every response efforts and recovery efforts, there are always success stories and lessons learned. Throughout COVID-19 pandemic, we have improved visibility and awareness on occupational health more than ever. It has also strengthened and forged new partnerships, both at local as well as federal level, as well as with the communities. And we've identified new stakeholders for partnerships. There have been new or enhanced tools and resources that are now available, for free to stakeholders as well as state and local partners to use for either capacity building in occupational safety and health, or just preparedness and response for incidences like this. There's also a better understanding about our own communities and businesses. And as the pandemic continues to evolve, so do the workplaces and work processes, as well as our workforce, which demands that there is a continued need for integration into mainstream public health alongside infectious disease and emergency preparedness. Next slide, please.
So Kedki, this is Marie. We're going to have to stop here because we have 2 minutes till the end of the session. I know you have lots of slides and it's very informative, but I'm sorry, we're going to have to just end here if that's okay. Do you have a final slide you want to show?
No, I just want to give one final note that although, it's good that we end here because the last set of slide, although it's on a re-emergent topic, it also ties back to a lot of the content that was covered in the previous, presentations in today's talk, which relates to silicosis, which is occupational lung diseases. So if, people are interested in learning more about that, Marie, feel free to share these slides.
Thank you, Kedki. I'm sorry, we won't really have time for questions and answers, but I want to thank each and every one of our presenters for their very informative presentations, and thank them for taking time to do this. So NIOSH is still celebrating its 50th anniversary through the end of 2021. And so we do plan on having another webinar sometime in December. And there are many other events that are occurring over the next 2 months. So please stay tuned. Here's the website at the cdc.gov NIOSH about the 50th anniversary HTML. And thank you very much for your participation. And goodbye for now.